Hello, my name is David Gozal. I'm a professor of child health at the University of Missouri at Columbia, and I am also an editor for the European Respiratory Journal. In that capacity, I have the pleasure today of having a chat with Professor Walter McNicholas regarding a very recent paper in the European Respiratory Journal that appeared in the volume 52, 2018, entitled Challenges and Perspectives in Obstructive Sleep Apnea. And the first author was Dr. Randerath, with Dr. McNicholas as the senior and corresponding author. I was quite taken by this paper, which I would encourage all of you to read in its entirety. But decided that by having a chat with Professor McNicholas, we could address some of the important issues that are brought about by this article. Before any further ado, I would like to introduce Professor McNicholas. Walter, thank you for being today with us. I look forward to our conversation and discussion on the paper. And if you could you please introduce yourself briefly? And then tell us a little bit about what prompted this article, and then we'll get deep into some of the fundamental questions that really you address so nicely in the paper.
Thank you, David, and I'm delighted to participate in this podcast. By way of introduction, I'm a professor in respiratory medicine at University College Dublin in Ireland, and what prompted this paper was a group which was an ad hoc working group representing members of the sleep disordered breathing section in the European Respiratory Society and also the European Sleep Research Society. We got together and following discussions recognized that there were major challenges and limitations in our current understanding regarding not only the diagnostic criteria but approaches to management of the obstructive sleep apnea syndrome.
Thank you, Walter. So maybe I could go ahead and ask you what I think is a very important and certainly the first question, which is, do you think that the current diagnostic criteria that we use for the definition of obstructive sleep apnea as a disease, and that we usually use symptoms, presenting symptoms, or a spouse bringing the symptomatic patient screaming and kicking to the clinic, along with a laboratory or home-based apnea-hypopnea index? Do you think that combination as a diagnostic criterion is outdated, or would you care to speculate that this is still acceptable and this is the way we should continue practice?
Well, David, I believe these long-standing criteria are long due an overhaul and are substantially outdated. I mean, there are a number of major considerations which underpin this view. The most obvious is that recent epidemiological data indicate that the majority of the general population have sleep disordered breathing as traditionally defined based on an AHI of 5 or more. And indeed, moderate sleep disordered breathing based on an AHI greater than 15 can be found in anything up to 50% of the adult population, and in some reports in up to 75% of the elderly population. Now, these sort of prevalence figures cast doubt on the validity of these types of thresholds and prompt a rethink. The other aspect which I believe is very important in triggering a reevaluation is the well-recognized fact that AHI as a metric correlates very poorly with daytime symptoms and especially poorly with daytime sleepiness. So when we combine the traditional metric of AHI with the major daytime symptom of excessive sleepiness, we're really combining two metrics that correlate very poorly with each other. A further consideration in this regard is that we increasingly recognize that there are different clinical phenotypes of the disorder. For example, there's a phenotype associated with lack of sleepiness. There's a phenotype that is associated with insomnia. And these different phenotypes aren't well reflected in the traditional AASM criteria for defining and grading OSA severity.
Well, thank you, Walter. And I concur certainly with the position that you're taking, that in the context of cluster analysis, a very large data set, it has become apparent that there are clearly different phenotypes that are not necessarily captured by the current diagnostic criteria. At the same time, it is clear that using a single metric such as the AHI is missing a very substantial wealth of information contained either in any of the recording studies that are done to define the diagnosis. And so should we therefore start thinking well beyond the AHI into other metrics or measures that are currently captured or potentially future measures that could be captured within a study of so many hours at home or in the laboratory in order to enhance our ability to assess, the severity of sleep disorder breathing, but at the same time to look at potential markers of morbidity that are embedded already in the fabric of the measures that are recorded within the sleep study.
Yes, I do believe that we should be going well beyond the AHI in evaluating OSA and sleep disordered breathing. I mean, for example, there are many other signals that are currently available and indeed are recorded in many of the monitoring systems that are available, and these include oxygen metrics, snoring, cardiovascular metrics such as heart rate, and indeed measures of flow limitation. And these measures may be easier to evaluate than AHI, and indeed may be more suitable to ambulatory monitoring. Indeed, the AHI may be inferior to some of these other measures in predicting disease severity and, for example, predisposition to comorbidity. I mean, furthermore, there are pathophysiological phenotypes that aren't reflected in the AHI. For example, genioglossus responsiveness, the arousal threshold, loop gain, and other respiratory control disturbances. And these are important aspects which are increasingly recognized as important to the pathophysiology of OSA in general. And there's a growing interest in novel methods to evaluate these phenotypes, which are currently being validated. Thus, when we start to explore these existing measures in a more expansive fashion and some other newer methods that may be available which give added insight into the pathophysiology of the disorder, this may have the added advantage of gaining insight into individual phenotypes and individual management possibilities.
Well, definitely, the AHI will become a single measure. I think you completely echo your sentiment. That is, that the AHI should be viewed as a single measure, as a single metric, as an obsolete approach to evaluating a very complex disorder. It would be as if we took a single laboratory a test and built a disease around it. And so I think it's time to look at the disease and from many of its multidimensionalities and use the AHI as a corroborative element in the process rather than the fundamental cardinal centric type of measure that at this point is failing us. In the context you mentioned and measured both endotypes, but also the possibility of using oxygenation and saturation metrics as another way to get better insight into, for example, a very important aspect that is normally not very well assessed in our clinics. We evaluate the sleep, we evaluate the clinic, but then we do not due diligence, or at least a thorough due diligence, in evaluating all the end organ morbidities that are associated with sleep apnea. And so in that context, at least from the animal data, we know that oxygen intermittent hypoxia is a critical contributor to many of these morbidities. So maybe taking a deeper look at the information contained within the oximetry signal might be something that could provide us with better insight, not only into the severity of the disease, but also on its consequences. What do you think about that?
Yes, I would support that view very strongly. There is increasing evidence. You mentioned animal studies of intermittent hypoxia, but there's increasing evidence from clinical cohort studies that the ODI, which is a clinical measure of intermittent hypoxemia, is more closely associated with some comorbidities than the AHI. And there is evidence from large population studies for a superior association of ODI as a predictor of prevalent hypertension, prevalent diabetes, and indeed stroke incidence. The stroke incidence data is most closely associated with a measure of cumulative hypoxia, which is the cumulative time spent below 90%. And in that context, the oxygen saturation provides a signal which has great and broad potential. Not only can one look at the frequency of desaturations, but one can look at the cumulative burden in the context of CT90 and CT80, etc., etc. So it is a very rich signal. It's not well explored, particularly in general population studies. And I think with this growing evidence, I think there is scope for greater reliance on the oxygen signal. And in certain respects, it is likely superior to the AHI. One of the great advantages, of course, of the oxygen saturation signal as compared to the AHI is that it is easier to measure and thus very suited to ambulatory monitoring and indeed over several nights, which is a further and additional advantage.
Well, and in addition, really just to add even further ammunition to this argument, I would indicate that the oximetry signal also includes a plethysmographic signal of the pulse, and that through that there are a variety of approaches that could be implemented to look at autonomic nervous system responses on a bit-to-bit basis, as well as many other derivatives that can provide even further insights into mechanisms that may be driving morbidity as well. So I completely agree with you. But if we're thinking more into the future and with the issues of wearable technology, new biosensors, nanotechnology, and so on, proteomics, the genomics, a variety of omic technologies, how would you foresee a future where we abandon, quote unquote, the traditional sleep study, the way we look at it today, and start looking at much more innovative and disruptive technologies that may fundamentally replace or at least substitute some of the current approaches that we use for the diagnosis or of any patient with suspected sleep apnea? Would you care to put an oracle glasses and tell us what you see in the future?
Yes, I'd be happy to do so. I mean, my own perspective on this is that there is rich potential yet for expanded and more in-depth analysis of existing signals. And you've already identified one aspect of the oxygen signal, namely the pulse, which adds additional information. I mean, there are a range of cardiovascular variables from heart rate to pulse transit time, blood pressure variables, particularly nocturnal blood pressure dip, in-depth analysis of snoring and other similar types of variables. So there is great potential there which shouldn't be lost sight of. But looking more in in the future towards quite novel technology that may encourage a complete rethink of how we approach this question. I mean, one of the areas that I find particularly exciting is the developments around smartphone technology. I mean, people will be well aware that there are a number of apps already available which are quite simplistic in their approach in that they simply record gross body movement and they infer sleep quality from this signal. But some of the work that's currently underway has very exciting potential in the sense that there is technological development around the combination of video from the smartphone snoring recording combined with body movement, and in-depth analysis of these signals obtained from the smartphone may provide particularly interesting and useful information, and particularly in the context of screening patients, either to exclude a disorder or more particularly to identify patients that may require further testing in a more conventional fashion. And I think that is an aspect which we should really pay attention to, and it's not a case that a patient comes and they have a definitive study. It may be that we need to do a stepwise approach to filter out patients that can be dealt with in an algorithmic type of fashion. There are a number of novel signals. There's radio frequency, which has been under evaluation for a number of years, and the advantage of this is that it can evaluate body movement and also breathing movements without any contact to the patient. There are other indirect approaches, and there has been interest over a number of years around the whole area of biomarker evaluation, and there's a wealth of literature around the topic of biomarkers that may be potentially useful, particularly in the context of predicting end organ susceptibility and likelihood of comorbidity. Biomarkers around inflammation, oxidative stress, sympathetic excitation, fat metabolism, and microRNA analysis. All of these have been evaluated in different studies, and indeed your own group, David, has contributed considerably to this work in the past, and I'm sure are continuing to do so. Other respiratory data, such as evaluating arousal threshold, loop gain analysis, and indeed upper airway anatomy by novel techniques such as acoustic reflection, has the potential for adding further useful data. So the overall context of the future development, as I see it, is that not only will future technology have the potential to evaluate the presence of sleep-disordered breathing, but hopefully will also have the potential to evaluate individual susceptibility for health consequences of the sleep-disordered breathing. That would be the ambition, and I do believe it is potentially achievable.
One of the big questions in the room is always going to be, okay, we have diagnosed all these patients, and then we have a therapy that is very effective when it's used, but only a very small proportion of all those that need it actually use it the way they should. And so looking at the indications for CPAP therapy, and considering the fact that one, the adherence is what it is, and certainly far from ideal, and two, the recent studies that have shed what I would call a call to arms and concerns about whether this is a worthwhile therapy in certain circumstances. How do we move forward with one, continuing to disseminate the concept that patients, one, need to be treated with CPAP, since we are at lack of a better therapy at the moment that is non-invasive, and two, how do we address the, to a certain extent, valid concerns that are coming through the woodwork related to both the studies that have been done, but potentially to others, which seem to indicate that CPAP may not necessarily be the panacea for every patient with sleep disorder breathing.
Well, if I could address the second aspect first, I mean, the recent studies such as the SAVE trial and the RICADSA trial have provided sobering data and, as you intimate, a wake-up call to our group in the whole field. Perhaps we were a little overly optimistic in regarding CPAP as a panacea for everything, and some of the observational studies have perhaps given overly optimistic data regarding long-term outcomes. And of course, observational long-term studies do have that potential that they tend to overemphasize the positive result. But nonetheless, the negative studies have had limitations, which do need to be kept in mind. And for example, the SAVE trial was limited by poor patient compliance. The average compliance was just over 3 hours per night, and the patient population was confined to non-sleepy patients. So it's a very selected patient group with relatively poor compliance to therapy. And in that context, the RICADSA trial published in the Blue Journal 2 years ago gave interesting additional insight in that they demonstrated that where patients were compliant with therapy, that compliance was associated with improvement in cardiovascular outcomes. So overall, I think what these studies show is that yes, across the board, the data are sobering and may need some rethink of the role of CPAP in improving cardiovascular outcomes, particularly in the context of secondary prevention. But I think we're at risk of reading too much into those data, and I would take the view that what these negative studies have achieved is that they have brought our situation regarding CPAP and long-term outcomes into a state of clinical equipoise, and they justify further studies, perhaps in more symptomatic patients, and focused more on evaluating patients in the context of better compliance. It's not surprising that subjects who are just picked out because of moderate to severe AHI levels, who are asymptomatic from the point of view of OSA, would not be that compliant with therapy. So I think, in a sense, those studies have compromised our ability to fully evaluate this question. As regards the current indications, the approach our group would recommend arising out of our discussions is that in patients with moderate or severe OSA with related symptoms, particularly sleepiness, that this is a group where CPAP therapy is clearly indicated. And the experience of many sleep centers is that simply prescribing CPAP to a patient and sending him off is not the appropriate way to manage. Patients do need considerable education and considerable support, especially in the early stages of therapy, to ensure adequate compliance. And there's no doubt that, in our view, that appropriate patient support will produce good compliance in the majority of cases. A very interesting group is patients with relatively mild OSA who have prominent symptoms. And there's an increasing focus on considering a 2-month trial period on CPAP therapy to evaluate the potential relationship of the daytime symptomatology with the sleep-disordered breathing, which can be achieved by a 2-month trial. So I think this is an approach to CPAP therapy which is relatively recent in evolution, but I think is well warranted. Where the real difficulty arises in the context of indications for CPAP, we look at the group with severe OSA who are asymptomatic but with comorbidities. And I think this is a vexed area at the moment, and is an area where you will find considerable disagreement among experts. But equally, I believe that there are groups within that category where CPAP should really be considered. And to just give two examples, one would be hypertension, and especially where there's loss of nocturnal dipping. I think severe OSA associated with loss of nocturnal dipping does warrant a trial of CPAP therapy to assess the potential benefit in that context. And another group where a trial of CPAP therapy is warranted in severe non-sleepy patients is where there is either clinical depression or depressive type symptoms. And there is good evidence from many publications, both in clinical depression and other similar scenario of significant benefit from CPAP. So I think in the context of severe OSA without symptoms, one needs to take an individual approach where the individual patient is personalized from the perspective of treatment. And I suppose in the general context of management, it's that personalized approach to treatment that really is the key. The old style approach where you take the patient in, document an elevated AHI, document an Epworth Sleepiness Score, and then prescribe CPAP, I think that is too simplistic, and I think in the current state of the art is very much outdated.
Well, thank you, Walter, for a wonderfully clear and I think illustrative response to many of the challenges that will face us in the upcoming years as we try to sort out how better to delineate in a much more precise way who are the patients that really for whom CPAP therapy is clearly indicated, those who deserve at least a trial to see whether we can achieve some degree of benefit, and those, and possibly to try and also demarcate groups for whom institution of CPAP therapy may not yield the anticipated benefits, and therefore maybe alternative therapies need to be considered. With that, I think our time has come to an end for this wonderfully informative chat. I want to thank you, Professor McNicholas, for your willingness to discuss with us today on your provocative article in the European Respiratory Journal. Again, for those of you who missed the beginning of this podcast, we are talking about the challenges and perspectives in obstructive sleep apnea that was published in the European Respiratory Journals by Randerath et al. Again, Professor McNicholas, thank you very much for this very informative and really forward-looking conversation, and thank you all for listening.
Thank you, David, and it was a pleasure to participate.